I deal with on a daily basis. I'm the cardiologist in our Turner Syndrome clinic at UT Houston. I work in the medical center there. And I see adult patients with Turner Syndrome. Many of them have these questions, and so I've developed a way of approaching them over the years that I'd like to share with you. I did my residency and training at Baylor College of Medicine in Houston, and I trained in human genetics and did human genetics research, and then I did cardiology. So my focus on cardiology has always been from a genetics perspective, which seems to match well with what we see in Turner Syndrome, as it is has the highest prevalence of cardiac and vascular disease of any known genetic disorder. So I started my training initially working on aortic aneurysms, and then more recently focused on Turner Syndrome. I collaborated with Carolyn Bondi in her NIH study, and then in some of the subsequent studies using the registry, the National Genetically Triggered Aneurysm Registry, of which many Turner Syndrome patients have participated. So I'd like to discuss the way we work with patients who want to be active, kind of the safety issues from a cardiac and vascular standpoint. I'm going to give about a 20-minute presentation, and then after that, open it up to questions. And you can ask anything, especially things that I don't cover. This is going to be primarily from a cardiac perspective, but of course there are many other components to this. So I have many patients who have asked me over the years about how active they can be, whether they can be active, and under what circumstances do they need to restrain activities. So one question is, if you've been diagnosed with heart disease, what do you need? What sort of activities do you need to be careful about? What is permissible? Are there specific exercises that are better for patients with Turner Syndrome who have heart disease? And then if you've had surgery on your heart or blood vessels, can you return to being active again? So one of the questions that we ask of all patients with Turner Syndrome is that we know that there's an increased risk of aortic dissection for anyone with Turner Syndrome, regardless of how healthy you have been. And that risk is not proportionally distributed. So we know that almost all patients with Turner Syndrome who have had aortic dissections have one or more of these risk factors. And of those, the most important one is actually high blood pressure, hypertension. But we also know that patients who have other features are more likely to have aortic disease. And so when we start talking about how safe is it for someone to exercise, at the top of the checklist are these factors that I'll go into in a little more detail. But if you have several risk factors, then you are considered to be at higher risk. And that necessitates maybe a little more careful preparation before you start doing moderate or high intensity exercise. So we'll talk about how to grade out exercises you might want to do, like what activities are safer and what are riskier, and then how to assess your own personal risk. So is there any evidence out there that patients with aortic aneurysms or have had aortic dissections can exercise safely? That's where I started from when we talk about the risk for Turner Syndrome patients. And so the safety of moderate exercise has been validated for patients with other forms of aneurysms who don't have Turner Syndrome. In fact, it seems to help quite a bit. It lowers blood pressure, and in many cases, it's actually been shown to prevent disease progression and reduce risk. So in general, exercise should not be considered restricted in patients with heart and blood vessel problems. In fact, it may actually be more beneficial if we can balance out that risk and be prudent about how we proceed. So, and we also know in animals with the same sort of mutations that cause human aneurysms, in this case, a mutation that causes Marfan syndrome, if you exercise them, it seems to actually slow down the growth of the aneurysm. So this is an important fact that anyone with Turner Syndrome should pay attention to, because we consider Turner Syndrome an equal risk for aneurysm progression as in Marfan syndrome. So how safe is exercise for patients again? So one of the things that's often misconstrued about exercise is that it induces aortic dissections, because there's this research that showed that patients who had dissections were more likely to be engaged in vigorous activity. Things like weightlifting, things like running, things like extreme exertion before they had their dissections. And so that's enough to often give people pause and think that maybe they should pull back from activities due to this risk. But that's a perception that's largely incorrect for several reasons. First of all, the intensity, meaning the strength or level of the exercise, has a big determinant of risk. And then how quickly you exercise, how much you ramp up and cool down, and also what type of exercise has a major determinant of risk for aortic disease. And so a lot of the patients in these old reports were doing very vigorous exercise and had not had any sort of testing, or were not taking any sort of medications before they had their dissections. So we know that being on medical therapy and being followed by a doctor reduces risk for all types of heart and blood vessel problems. And that's probably the main message I'd like to get out, is before you start any sort of exercise, the first step, get a thorough medical evaluation, understand your aortic disease and your risk, and get monitored. And then just by doing that, your risk of having any problems with exercise will go way down. So when we talk about the risk from exercise, the main risk is high blood pressure during exercise. And this cartoon kind of illustrates what I mean. So you can see that in a normal situation, you have kind of a low flow state where the pulse, that pulse you feel in your wrist, might be relatively mild, low heart rate. You exercise, now all of a sudden the pressure that's going through that vessel, when you feel your pulse pounding, your heart rate picks up, that is that pressure pushing outward on the blood vessel. And so the idea is that if this pressure increases and you have a genetic risk, you can trigger a dissection, because that pressure is what determines how likely the aorta is to rupture. And so the risk for rupture here would be how thin is the wall, whether you have an aneurysm, whether you have high blood pressure pushing on the aorta. All of those things could make a difference if you are at a genetic risk for aortic disease. And we know again that these patients who have other kinds of heart and blood vessel problems are basically more likely to have thinner aortas. And we know this because we've done a surgical evaluation of these patients who've had aneurysms repaired, and the aortas tend to be much thinner than average. So the idea is that with high blood pressure comes increased risk, but it has to be combined with someone who has an abnormal aorta to begin with. So when we start with ways to reduce your risk, the number one way in Turner syndrome that you can reduce your risk is by understanding your blood pressure and taking steps to control it. And by controlling it, we mean a top number that's less than 130 and a bottom number that's less than 80. That is not technically high blood pressure for people without Turner syndrome, but because of these extra genetic risk factors, we take efforts to make sure that people have really normal blood pressure. We try to get everyone's blood pressure at 120 over 80 or less. And that's really normal. That's not anywhere close to hypertension. But again, the idea is that we think that this will minimize the risk as much as possible. So the other main feature of this is that blood pressure and your heart conditions will change over your lifetime. And as you may have read in the recent guidelines, we really emphasize this point that Turner syndrome heart disease and blood vessel disease is a lifelong disease. And so it requires lifelong follow-up in children and adults with once yearly blood pressure checks, heart monitoring, and imaging of your aorta. We can talk about that. That's really another talk altogether. But knowing what your heart and blood vessels are doing is really important so that you understand your risk. And again, just having this monitoring and knowledge, we know reduces your risk to have an aortic dissection. So the other thing about blood pressure is that it's very sneaky. It can often be possible to have high blood pressure and not realize it. The reason is that a lot of the blood pressure measurements we get at home or in the clinic don't capture the full extent of the way your blood pressure changes. And we know that this can be abnormal in patients with Turner syndrome because their blood pressure can get really high at some points in the day and really low at other times. If you only measure it a few times a day, you can often miss that. And we know we miss it in about a third of cases, where we either think it's higher than it is or lower than it is. And that's why we often do ambulatory blood pressure monitoring on patients with Turner syndrome want to be active, because we want to know exactly how high it gets so we can make recommendations that match what the patient needs. And this is coming from the guidelines. So again, we stratify patients depending on whether they have things like coarctation, bicuspid aortic valve, or high blood pressure in terms of their risk to have a dissection. And that determines how often you need to do things like see the doctor, go get your echocardiograms, get your CT or MRI. So you really need to know this so you can be sure which schedule you're on, because you can see there are lots of different options here in the guidelines. And that really is something that patients need to know. I go through it with them. And then you carry this with you so you know when you're due for your next test. As I mentioned, the number one thing that we control is blood pressure to reduce your risk of developing an aneurysm or dissection or needing heart surgery. There are two medications we as cardiologists recommend for patients with Turner syndrome, a beta blocker or a medication called losartan. Many of you might be on these medications. The goal is really to do two things. So one, of course, we want to get the top number of the blood pressure down as low as possible that you can tolerate. And the second is that we know that these medications actually protect the aorta. So they do it in different ways, but the goal is they actually reduce your risk to have an aortic dissection. And so we believe that everybody with Turner syndrome and at least one of those risk factors that I mentioned there, so going back, one of these risk factors should be on medication. And that includes things like planning to get pregnant. If you're able to get pregnant, you should be on prophylactic medication because pregnancy is a risk for dissection in Turner syndrome. And even patients who've had previous surgery may think that your aorta is now normal. That's not the case. Actually, having previous surgery still is listed as a risk factor because we know that the parts of the aorta that aren't repaired are still at risk of dissection. So we recommend going on one of these two medications, and it's really a conversation that you have with the doctor in terms of what the side effects are, what to expect, and how often you need to keep monitoring or adjusting your dose. So besides being on medications or not, there are several aspects of exercise themselves that are important for your risk. One is the main type of exercise that you do. So exercise can be broken down into two components. You can have dynamic, which means things like running, where you're increasing your heart rate, but not putting a lot of resistance training into your routine. And then isometric, that's where you're not moving, but you're putting a lot of resistance, like you're lifting weights, you're bearing down, you're feeling that pressure inside your chest or stomach. So those isometric exercises actually raise your blood pressure substantially more than the dynamic exercises. And so one of the things we recommend for patients with aortic disease is to try to increase the dynamic component of exercise and decrease the isometric component as much as possible, because that will reduce that risk of very high blood pressures that we know is the major risk for dissection. So in our guidelines for our clinic, we tell patients you can lift whatever weight you can comfortably lift without having to bear down. That bearing down, like as if you're lifting a heavy weight, is what increases blood pressure in those isometric exercises. We do recommend dynamic exercise, and so this chart is something I show my patients. It tells you kind of which categories of exercise fall into the dynamic range and the static range. And so we want to live down here, right at this corner, where you're more likely to be dynamic and less static. So things like walking, hiking. I put sex on here because a lot of people do wonder what the exertional components of sex are, and it's actually quite reasonable for most patients with aortic disease. But you can see that as you get up here, you're talking about things like lifting heavy weights, and that's mostly isometric. There's not a lot of movement there. We know that that's a riskier endeavor for people who are at risk for dissection. So you can actually look this chart up online and you can figure out how many, these are metabolic equivalents. This is how intense the exercise is. Generally you want to get between 4 and 6 metabolic equivalents in your exercise, so that's in this range, in order to have a moderate workout. So the other factor in Turner syndrome that's really important is planning your exercise for the right time of day, a lot of people don't account for this, but your blood pressure does vary substantially from the morning to the evening, and in Turner syndrome this can be pronounced. In our studies so far, we tend to find that patients with Turner syndrome have pronounced peaks at particular times of day, and so knowing this, you can actually schedule your exercise routines to avoid those peaks, so your blood pressure is lower. And this is an example of a 24-hour type of blood pressure monitor that we would do on somebody who wants to start exercising, who is at risk, as one of those risk factors. And so you can get information like this. This is a tracing of their blood pressure over 24 hours. And you can see that in this case, there are several patterns that we find. In some people, the blood pressure drops dramatically for half the day or part of the day. And for others, it does not. So knowing this would be important to evaluate your risk. Things like when you should take your medications, when you should exercise, to avoid things like having blood pressure that's too low or too high at certain points in the day. So we also know that in patients who've had aortic dissections, this pattern here, one of these patterns, can actually tell us more about your risk than just the blood pressure alone. So it's not just how high or how low it gets, but the pattern over 24 hours that can tell us if you're actually at higher risk, and if we use medications to change that risk, we can actually reduce your risk further. So we can change the pattern, and we can make that those peaks and valleys even out a little bit. We know that patients who are treated that way tend to do better over time. The other thing that we look at is if you're exercising, how high does your blood pressure get while you're exercising? So I have a lot of young patients. Young patients like to be active. They like to ride their bikes. They like to run. One of the questions is, your blood pressure may be normal while you're sitting here in clinic, but if you are doing something that you like to do, how high does it actually get? And we can actually test that by putting someone on a treadmill and measuring their systolic blood pressure. And so we could actually figure out how high it's getting. And if it gets above a certain number, like in this case 160 to 170, we know that you're more likely to have an aortic dissection. So we can actually prescribe a type of exercise that avoids that number based on how people respond on the treadmill. So this would be an example of someone who's on a treadmill. We hook him up to electrodes so we can measure the ECG, and we take blood pressure every couple minutes during exercise as the treadmill gets faster. And here you can see that this person had a normal blood pressure when they stepped on the treadmill, but as soon as they came and started to do moderate exercise, the blood pressure goes up past 180, which is severe hypertension. You can see that it remained elevated even after this person went into recovery after exercise. So this would be a marker of high risk. You want to avoid severe prolonged blood pressure increases because, again, this is the major risk for dissection. And so this is a tracing of what the blood pressure would look like. And if the blood pressure doesn't drop at the end of exercise, that's actually what we look at, one of the major risk factors that we look at. We want to make sure that that blood pressure is dropping, would be a normal response. But in Turner syndrome and some other patients who have aortic disease, we know that that sometimes doesn't happen. So that can give us a lot of information about risk. So when we have patients, young patients, active, healthy patients who want to start exercise but may have risk factors, we start with a history and physical to try to evaluate all the things that I talked about to see what their risk might be. Then we might do an echocardiogram and imaging to see if they have an aneurysm or any other undiagnosed heart or blood vessel problems. This could be followed by a genetic evaluation if we think that the patient has other risk factors or an unusual genetic component in Turner syndrome. We can do a treadmill exercise test to see how high their blood pressure gets at the exercise levels they're proposing to do. And we can also check their ambulatory blood pressure. So this can lead to a change in their medical therapies, and we can actually prescribe exercises that are safe based on these results. And so this allows us to get a lot more information than I could obtain just by taking a history or doing a physical exam in the office. And so this kind of tells you how we might risk stratify patients based on whether they have had a dissection or an aneurysm, whether they have other heart disease like VAV or coarctation or previous surgery, and that would let us identify a blood pressure target that might be safer. We would choose a lower target for patients patients who have higher risk, and absolutely no isometric exercises. For patients at low risk, limited isometric exercises might be allowable, depending on the situation. Again, individualization is important. You can't tell everyone that they can't do certain things, and you can't tell everyone that everything is okay. It really depends upon the person who's standing there in front of you.